talk of the first presentation, the main term we said was the denominator. And the main term being the denominator, there can be times when we get a persistent mental posterior position. And how does it happen? When you look at its mechanism, usually it is the same. The lies longitudinal attitude, this time is incomplete extension. Remember, in first presentation, we have the attitude of complete extension, but somehow, as labor progresses, this head is incompletely extended, though the presentation remains the face. But this time, the main term lies posteriorly, either on the right or on the left posterior aspect of the pelvic cavity. And the denominator this time becomes the synsput. Because previously the denominator was the main term. When it is fully extended, it is the main term at the lowest part. But when it is partial flex, then this time the denominator becomes the synsput instead of the main term when it came in as a secondary first presentation. So what happens is internal rotation of the head occurs. With uterine contractions, this increases flexion and descent occurs, and the synsput becomes the leading part. This time it is the synsput down, as it is the synsput being more down as compared to the main term in the full first presentation, because in full presentation it is the main term which is the leading part, but in partial it is the synsput becoming the leading part. And it meets the resistance of the pelvic floor muscles, and it rotates an eighth of a circle forward to lie under the symphysis pubis. The chin goes into the hollow of the sacrum and no further mechanism. So because it is the chin, the synsput leading, as it rotates, it brings this chin into the posterior aspect of the pelvic cavity. So this is what it means, that as it goes, somehow the synsput becomes the leading part. And as it tries to rotate, the chin is caught up in the posterior aspect of the pelvic cavity. And by this, the synsput is slightly lower than the main term due to the rotation. But again, because the chin is trapped up in the pelvic cavity, no further rotation occurs. So this baby is caught up. So what does happens? The face becomes impacted because the head and the neck are completely extended and no further extension can take place. So what we call persistent mental posterior, when it happens, the head becomes trapped up into the pelvic cavity, which is different at one time when we have the mental posterior position, whereby there is internal rotation of the head, and instead of the chin rotating an eighth, it can rotate 3/8 of a circle. That is, it rotates from, because it is mental posterior, it can rotate like in OPP from the posterior part of the pelvis, and it rotates anteriorly and brings the chin under the subpubic arch. So this is also a long rotation in first presentation. And this long rotation, it will bring the synciput, it will come under the symphysis pubis. And due to further extension, the chin will escape under the subpubic arch, by the method of extension. More extension, the chin will escape. And then we shall continue with our normal mechanism, whereby we shall have flexion, and then restitution will take place. Internal rotation of the shoulders will also take place in the transverse diameter, and they will also rotate to 1/8 of a circle to come into an anteroposterior diameter of the pelvic outlet. And then this baby will be born by lateral flexion. So in first presentation, we also have 3 outcomes. The first outcome is a short rotation when we have mentor anterior. When the mentum lies anterior and rotates into a short rotation, the mentum will come under the symphysis pubis, and we shall deliver this baby first by extension to deliver the chin, and then lastly by first by extension to deliver the chin, and then last by flexion to deliver the occiput. That is the first outcome of mentor anterior. Then we have a second outcome of mentor posterior, whereby this mentor posterior can have also a long rotation. And when it gets a long rotation, it will bring the mentum anteriorly. And this mentum being anteriorly, it will be delivered like in the short rotation. Or we can have what we call a persistent mentor posterior. That if the mentum lies posteriorly, instead of rotating 3/8 anteriorly, it will rotate 1/8 posteriorly. And this rotation of 1/8 posteriorly, it will bring the mentum to get caught up in the sacral curve. And if it is caught up in the sacral curve, the synsput will now become the denominator. And because the synsput is now the denominator, the head will be caught up in the pelvic cavity, and no more descent will occur. And this mother will get what we call obstruction. So this mother may need to be rushed to theater. Complications, I don't need to explain the complications, but to mention by a few, we may have extensive perineal lacerations, maternal exhaustion due to prolonged labor, instances of instrumental delivery called prolapse, puerperal sepsis due to increased vaginal examinations, obstructed labor, like we have said in persistent mentor posterior, rectal and vaginal fistulae can also occur. To the baby, of course, we shall get fetal hypoxia due to prolonged labor, intracranial damage, edema of the face, and even damage to the larynx due to extension of the neck. So with these few remarks, I feel we must appreciate the first presentation, learn how to diagnose it so early, and refer this mother to hospital for further management, because we never know, anything can happen. It can come in as a first presentation, but later it can come a persistent mentor posterior, which cannot be managed in a maternity center. So if this mother, we can diagnose it early, then we refer this mother to a bigger health facility center. With these few words, we call it a day.